The bottom, the American Neurophysio Association have got lots of lovely patient fact sheets, so you can give those out, but they're also useful for clinicians as well. Okay. So that was a whistle-stop tour. I'm going to do another whistle-stop tour now. So visual vertigo is often bandied around, and it's a symptom. It's not a pathology. So someone might have vestibular neuritis. On top of that, they've got visual vertigo. And all that means is it's vertigo that's triggered visually. So these are the people that come to see me and say, I walk in the supermarket and I fall over and I feel sick and I have to leave, or I go for a walk in the woods with all the vertical trees, or traffic is a real problem, or in fact big wide open spaces can be a problem as well. So it's the environment that triggers the vertigo, and they're patients that are very much dependent. They've become totally dependent on their vision to balance. So then when you put them in a complicated visual environment, they've got this conflict between having to use their vision to stay in equilibrium and balanced, but they're also having to decipher that complex visual environment. And they tend to really describe... Ooh. Okay, I was just going to talk through this then. They tend to describe disorientation, so that's the big thing that they talk about, and they've used a whole array of different narrative. I don't think there's a typical sort of narrative. They use their own language to describe basically feeling really disorientated, but the key is where it's happening. The vertigo situational questionnaire is a lovely, really simple questionnaire that helps give a bit more of an objective measure. Because the narrative is so varied, I find this quite helpful to just ask people, it's just statements, they mark it out 0 to 4, or not applicable, or not tried, and it just gives a whole range of different situations where they might be experiencing vertigo. So you've got, these are some examples of some of the questions, so moving sort of curtains, water, driving over the brow of the hill. It's 19 questions, and as I say, it's a really nice, quick, simple thing to do. So that's quite a nice diagnostic as well as objective measure. Treating these guys, caution. It's very, very easy to make their symptoms worse, and they will. And I think that's something that you have to say early on, like, we'll probably make you worse before we make you better. And that's part of the journey of learning how to sort of explore those symptoms. It's around graded exposure really to those visual environments that they find difficult. So you can use the VOR exercises we talked about before. You can use those backgrounds I was talking about. That sometimes can be really helpful to start them with the basic exercises and then build up to having a visually busy background. Optic kinetic stimulation is where you've got a moving target, if you like. So you can use things like a disco ball. So you're creating a moving visual environment, and then they can do balance exercises, etc. within that environment. I'll show you another little video in a minute, which is a tool I sometimes use with people. Chris Bowles, who works through here sometimes, he's a visual vertigo expert, and he has a DVD that he works with people, and it has a whole lot of different kind of visual environments on the DVD, and then you find the ones that sort of trigger your symptoms and work with that. Anxiety management, huge. Lots of education around autonomic responses, because you see a lot of that in this client group. Lots of sort of relaxation, diaphragmatic breathing, and as I say, helping people understand that they can dampen their symptoms down when they've increased as well. And education, and good old-fashioned balance work just to reduce your visual dependency. So lots of work with foam and trying to get people to use their vestibular system a bit more than they have been using. So this is just to give you a little idea of the video I was saying. It's a YouTube video. It has these horizontal lines, and then it changes to vertical lines, and then it has this little pink ball that moves around. It's about 10 minutes long. It's got some music in the background, so I tend to get people to just watch it. And then you can also do your kind of balance exercises. Again, start really small and build up. So it's like using a static background, but you're using a moving one. It's quite nice, neat, tidy. You can do it on your computer or your phone or whatever. so it's quite a good little tool.
And is the aim that they're watching the red ball?
Initially it hasn't got the ball, it's
Right.
just, so yes, once the ball comes in then they're trying to track it whilst, because then the lines are moving as well, so it's picking that out. So again, just some little resources for you. Another YouTube channel which is called Sixes Full of Nines, but it's got loads of stuff and it's got a lovely video about visual vertigo on there. The American Physiotherapy Association have got a vestibular special interest group and they've got 20 plus podcasts. There's an excellent one about this visual vertigo on there, which is done by Dr. Pavlo, who is based down in London at King's, and she did loads of the research on the optic kinetic stimulation stuff. So there's a couple of podcasts on there that are worth listening to if you're interested. You've got a long car journey. Vestibular migraine. Last whistle top. I'm flying through them. You know, we were talking with the vestibular neuritis that was a problem in the peripheral process, information delivery. Vestibular migraine is a problem with the processing of that information. It's a fairly newly recognised diagnostic within the International Classification of Headaches, so it is there. And it's as simple as vertigo caused by migraine. Nothing more technical than that. However, it's a weird and wonderful thing. So vestibular migraine affects about 1% of the general population, but it's about 11% of your dizzy population. So actually it accounts for quite a lot of people that would come through with dizziness. As I said, it's within the International Classification of Headaches. The people I've seen there's no typical presentation, I would say, but they can present with episodic vertigo, dizziness, disorientation. They might have headache with it, they might not. They might have headache sometimes, they might have dizziness sometimes. So it's not a clear journey together. The diagnosis tends to happen if someone's had a history of migraine and then they start to develop vertigo and dizziness, and they've excluded all other causes of potential dizziness. That tends to be the way that the diagnosis is made. Again, they may or may not have photophobia, phonophobia, they may or may not have auras, they're likely to have some postural instability. They might have some of these ocular signs, so they might have some of this inability to stabilise their gaze again. A huge percentage, half of them will have a comorbidity of anxiety and depression. Chicken and egg, I think, is probably what experience would say, but also what the literature would say as well. So again, you can see that you need lots of education because it's a fairly new diagnosis. Lots of GPs are unaware of it, so again you have that slight cycle of people not feeling terribly supported by the system because it is quite an unusual diagnosis.
So the only difference in the normal migraine for such a thing is that there is more dizziness. Okay.
So your physio assessment, there aren't some nice neat tools like there are with vestibular neuritis. It's very much an individual assessment. I've started asking everyone I see now, have you got a history of migraine? Even if they've come with a nice clear diagnosis of vestibular neuritis, and I'm still asking because I think it's really important to understand that there is this relationship between the two. What are triggers? Sometimes it's easy, sometimes it isn't. Ruling out BPPV, so benign positional paroxysmal vertigo, which is your Dix-Hallpike test, nice and easy. Rule it out, because if it is that, because that comes with episodic vertigo, it's so easy to treat. It's, for a 30-second test, you may as well rule it out in the first place. And then I think it's lots of these things. So are they avoiding situations? Have they got visual vertigo? Have they got motion sensitivity, which would be much more like your car sickness type symptoms? Have they got ocular motor dysfunction? Have they got problems with their balance? Have they got autonomic activation? Have they got, I said visual vertigo. So they can have all of these or none of these. So again, it's very much just giving you a feel that unlike vestibular neuritis that's quite stereotypical, this is very unstereotypical. And I tend to use this Vestibular Rehab benefit questionnaire because it has different subsections of symptoms and quality of life in there. So it's nice to give you a feel of, if they're scoring very highly on anxiety but very low on motion sensitivity, it would sort of guide treatment a little bit. And that's the website address. It's University of Southampton. Treatment ideas. Depends what your assessment says, really. But lots of education, lots of support, lots of empowering people to get the medical management sorted. Because without the medical management, whatever we do is not necessarily going to be very helpful. They need to have their migraines managed. So it might be trigger management, diets, other particular sensory triggers. Is there a hormonal component to it? Anxiety and stress management, whether that's at the sort of basic level that we can do, or whether that's referring on, and vestibular rehab, depending on what you think is going to be useful. And I wanted to just bob this in just to give that sort of notion of sensitivity, really. So I would probably, starting with balance exercise, and again, your quite traditional balance exercises are probably less likely to trigger vertigo from a migraine sort of point of view, whereas your adaptation exercise, the BOR ones we talked about at the beginning, they're more likely to trigger some symptoms. So it's kind of working through habituation exercises, as it says on the tin. So what triggers off your symptoms? Right, let's do a graded exposure to those. So it's kind of caution, work through gently with all the other sort of management stuff that comes with it. I think they're a tricky group to work with. So I've found. Again, I just refer you sort of to the American Physiotherapy Association. They've got a couple of videos that are really good, as well as their podcasts, and then the bottom one's another video, which is a neurologist talking about vestibular migraine. So they're quite nice, just introductions to the topic. Okay, we're back to what have you learned. So, don't talk to anyone, write another number, or the same number on your post-it notes. So, have you learned something? Reassess, do you think now you're an expert, or perhaps you weren't as much of an expert as you thought you were, or you're less of a novice than you thought you were. So write a number down, have a think. When you've written your number down, turn to the person next to you, tell them just something that you might do differently in your practice now. Whether that's, well, I'm not giving you any clues. I'm not saying you'd be a vestibular expert. So have a little chat with the person next to you.
Also, this.
I think we always focus just on BPPV, aren't we?
Yeah, I'd always focus on that.
Level fixed business is just
It's a diagnosis that gets thrown
Oh,
on us,
yeah.
and it's not, and doesn't get, and gets ignored sometimes with other people where it could be so
blanket diagnosis, isn't it?
Yeah.
Mm.
Go on, show me your numbers.
6 to 7.
Oh, lovely. Super. Okay, thank you very much.
Thank you.
Any questions, I guess? No, nothing. Okay. Thank you for your time.